Firstly, an apology. Just as we were about to go live, we lost the internet connection, so we had to reconnect. So I hope you are now all connected and can see the slides and can hear me. My name is Julie Wood, Chief Executive of NHS Clinical Commissioners. I'm going to be speaking quite a bit today and sharing the webinar before handing over, not to Carol Roberts, who's listed on the slides, but to Bhavna Reddy, who works with NHS England and is providing a lot of technical support with regard to this work. Also on the line, I'm really pleased to have Sue Smith from Prescript, who will be able, I hope, to answer any technical questions that we can't cover off, and also Brian McKenna, who also works with NHS England and with CCG as well. So we have just under an hour to go through the slides, which are to do with, as the title suggests, conditions for which over-the-counter items should not be routinely prescribed in primary care. So the agenda for that time is, as on the slide, to tell you a bit about, or remind you really, what we're doing, why we're doing it, and what the proposals are looking like, and critically, what you really need to be thinking about doing now. Keen to have opportunity for questions and answers, but keen to have this webinar as early as we could in the consultation period so that you can do the work that needs to happen in good time to feed into the consultation process. So, overall objectives, I hope this isn't new to the people who are listening in and reading today. As you all know, we've been working on your behalf for a number of months now, focusing in on how we can prioritise use of the limited NHS funding that we have. You'll know that medicine spend is the second largest after staffing costs, and you can see the extent of money that is spent, and also the very steep increase that we're seeing, an increase of over 29% from 13 billion in 2010-2011, and that trajectory looks set to continue. So we need to think about support CCGs in actually how they can support smarter use of resources that will mean realising some funding for use on other high priority areas that also have positive impact for patients, but about supporting improvements and deliver transformation. So a number of objectives as to why we're doing this, not just about it's a lot of money, but also critically it's about supporting the principle of self-care. So we know that empowering people with confidence and information to look after themselves gives them greater control and encourages the behaviours that will help prevent ill health. So it's not just about the money, it is about supporting the principle of self-care. But it's also doing two other things, which is about reducing demand on general practice. You'll know the extent of consultations and the cost that's estimated to be spent on consultations on these sorts of items. If we can realise some of that and liberate that, then again, that can be used for other higher priority consultations. But it's also about addressing increased price and other costs. We also know that the cost of the NHS for many of the products that we're talking about is inflated beyond the price at which they can be purchased. The oft given example is paracetamol, but it's not just about paracetamol. It's about other drugs as well, for example, antihistamines in some instances. So actually we're trying to reduce the spend on some of those items where that's appropriate to do so, because the NHS pays far more than it would cost us as an individual to buy them. And finally, it's about reducing variation. We know that a significant number of CCGs are considering, and a smaller number have already implemented policies to limit spend on over-the-counter items. So actually doing something that brings national coordination to that process and brings national support from NHS England for local decision making would help a lot and in ensuring consistency across the country. And I am pleased and grateful to the support that we've had from NHS England colleagues for this work so far, and as we move forward into the next few months. So just a couple of graphs showing the variation. Here's the variation graph for analgesia spend per thousand patients, and each bar represents a CCG. So we can see still a significant level of variation that exists, and we need to look at how we can tackle that. And here's another one for travel sickness. We have already sent out to each CCG via my Leaders Bulletin, so people on this call should have seen my last Leaders Bulletin that went out very early in the new year, that gave you those graphs for each of these sets of conditions we're talking about, and you will be able to identify where you are, which bar represents your CCG, and so you can see what your level of spend is going on. In the same way as we developed the list of 18 medicines that we first started with in terms of looking at limiting routine prescribing, we sought general comments through that consultation, and feedback was generally supportive, with 65% agreeing that some sort of restriction ought to be considered. So we then, very rapidly I would say, developed the proposals for consultation, involving the clinical working group that has representatives from CCGs, from NHS England, from the Royal College of GPs, from the GPC, from NICE, from the Royal Pharmaceutical Society, and a few others, to actually get their take on the proposed approach. We also mapped the massive number of OTC items to conditions for which they're typically prescribed, and then refined the approach to actually propose that we did base potential prescription prescribing restrictions based on condition rather than item name or formulation, because it would just be totally unwieldy to do it in that way. We then used the NHS Business Services Authority data to actually look at what that will potentially yield. And that suggested that overall spend for all of the conditions, if we were doing everything, was 569 million. We then analysed the medicines falling within the top 90% of spend to identify how those medicines could be classified. And when we did that, it actually took out a significant chunk, but we then estimated that restricting prescribing for minor conditions may save up to 136 million once all discounts and clawbacks have been accounted for. So that's the size of the pot, if you like, that we're potentially consulting on during this phase. I'll hand over to Bhavna now, who's done a lot of the hard work in doing all that, slicing and dicing of data to actually look at how we should develop this. So Bhavna's better than me to speak to this detail. So over to you, Bhavna.
Okay, thank you, Julie. So this slide shows the list of the 33 conditions that we mapped all the data to. There's 9 more conditions here than was in our initial consultation in July. We also included 2 items on there, probiotics and vitamins and minerals. And we then decided that we needed to group these conditions into an easier to manage format. So we identified 3 categories that we proposed the conditions into. So the item of limited clinical evidence of effectiveness, so they're the vitamins and minerals and probiotics. Then there's the self-limiting illnesses. So these are illnesses that don't require medical advice or treatment because they'll clear up on their own, but some people might want to purchase over-the-counter medicines just for symptomatic relief. And then there's a final category around minor ailments that are suitable for self-care, and you can buy over-the-counter medicines from a pharmacy for these. We then developed with the clinical working group the guidance that is now out for consultation, and we propose to make one of the following 3 recommendations, which are in line with our previous 3 categories. So essentially we're going to be advising that CCGs consider supporting prescribers in advising patients that to restrict prescribing in those 3 conditions, in those 3 categories. So for the limited evidence of clinical effectiveness, so in vitamins and minerals and probiotics, we're expecting prescribing to be restricted. Similarly, for the other 2 categories for the conditions, so for the self-limiting conditions, and again for the minor ailments that are suitable for self-care. The key thing to remember, though, is that the guidance focuses on restricting prescribing for the conditions outlined and not prescribing for individual items, because we know that some items, paracetamol, for example, are used for more chronic disease and for other things. And so we're not restricting prescribing of specific drugs as such. It's for those conditions. It's also intended to encourage people to self-care for minor illnesses as the first stage of treatment. So we would be expecting them to do the self-caring, and then there's various categories here that we've outlined where we would expect prescribing to continue. So these are mainly treatment of...
Bhavna, we've lost you. Oh dear. Bhavna, I don't know if anybody else can hear us. Brian, can you hear me?
I'm just joining now. Do you want me to take over from Bhavna?
Yes, please. Do you know where Bhavna's got to?
So I think we're just finishing off this. So yeah, as Bhavna said, we're really trying to encourage people to self-care for these minor conditions, visit their pharmacy for a supportive call before booking appointments in general practice. So if we could just move on to the next slide, please. So we do have specific exceptions. I might just cover the first few, and then Julie, if you want to come in on the last exception. So obviously, where a product can't be sold over the counter by a pharmacy, we can't, we still need a prescription. This commonly occurs. A lot of the common treatments you'll be used to seeing in pharmacies sometimes can't be sold, maybe perhaps to children. Pregnancies typically another exclusion where that has to be supervised by a doctor. Some of the conditions mentioned, for example, coughs, etc., could be an underlying presentation of an underlying more serious disease. So where a GP is consulting with or other prescriber sees a patient and they think it might actually be something more serious, as well as trying to rule that out, it might be appropriate to prescribe in that situation. Other exemptions that we have, where we think they're really, obviously we're producing guidance for the whole country for every patient, it's not going to be appropriate. So we have left it in if there's some clinical situation which will occur that we just aren't able to consider in a guidance like this. We've left it to individual prescribers to make that decision themselves. As a result of the consultation, a lot of feedback we got was around people who financially might not be able to purchase these medications, or certain circumstances will allow them make them unable to purchase. So we have left an exception in there. We've crafted the following test. So patients where clinicians considers that their ability to self-manage is compromised as a consequence of social, medical, and mental health vulnerability to the extent that their health and or well-being could be adversely affected if it left to self-care. So that is the exception. We're particularly thinking about very vulnerable patients, perhaps there might be safeguarding issues. We would really like feedback on this exception during the consultation, so we'd welcome your thoughts on this particular exemption. I don't know, Julie, if you wanted to say more about that particular one.
Yeah, so we've had lots of conversations and difficult conversations about how do we respond to the need for vulnerable patients to still be able to get OTC medication, and if vulnerability is about ability or inability to pay. We've crafted this sort of social, medical, and mental health vulnerability to really potentially cover that. It will be for the prescriber, because we need to reinforce that this is clinical commissioning guidance, and then it's for the prescriber for the CCG first and foremost, to decide whether it wishes to adopt the guidance and all that's included in it. If it does, then it is still at the behest of the prescriber to decide whether to prescribe or not, and use these exceptions. So we are hoping, but we want your views about that this particular exception would be sufficiently rounded to allow prescribers and CCGs to support where they do have concerns about health inequalities and about not wanting, obviously, to have people who would otherwise not be able to access the medicine that they need because of their social vulnerability to still get it. So it took some considerable crafting to get to not by me, I might add, by a GP colleague, to get to that position. So, but we do want your views on that as we go through the consultation. So back to you, Brian.
I'm back now. Yeah, I'm back. I don't know what happened there. It just fell out. Thanks, Brian, for taking over. So who's been involved in developing these proposals? So following the initial consultation, we engaged the Joint Clinical Working Group. We also engaged patient groups in developing and refining these draft recommendations. And the particular exception we were talking about was something that patient groups had fed back to us that they wanted included as well. So the stakeholder event which we held was attended by groups including the Patient Association, National Voices and Health Watch England, and they helped us refine and draft the proposals. We then so I think the last page is just, the next slide is just about the actual consultation. It's a 3-month national public consultation which will run up to the 14th of March. We've also got a range of face-to-face and online events running as well. So as well as these events through NHS clinical commissioners, NHS England have also set up a range of events. There's some webinars, I think, as well coming up through NHS England. There's also face-to-face events for patients and patient groups, and with specifically engaging with specific patient groups such as Older People's Network, and I think there's a Younger People's Network included as well. We're engaging with community pharmacy because they're obviously going to be involved in this. And
we just go back to, I think you're missing a slide, Wagner. So just before we get to that consultation bit, when we did engage with the patient groups at a national level, we are very aware of a range of concerns that still exist, and it is about this issue about vulnerable patients particularly. And so we are doing a lot to try to listen to and hear what people are saying, and by further engagement with particular patient groups, so that we do hear what people say about whether the exemptions that we've come up with go far enough to actually address the concerns and mean that patients who would otherwise not get access would continue to get access. And we'll see where we come to. So if I pick up then what CCGs need to do now, this is just like what we did with the 18 medicines. The ultimate decision about each CCG taking the decision about implementing guidance is for CCG to take. But we are trying to, as we did before, link this national coordination with local consultation and engagement. So, as this slide says, in order to ensure that the outcomes of the consultation can be implemented swiftly so that you can take your individual decisions, we would encourage you to undertake engagement or consultation with your population for implementation of the guidance in line with the requirements of the Health and Social Care Act. This will allow you to be able to defend any challenges that you haven't appropriately consulted at the time, and it will allow you to both hear back what we've had from a national coordinated consultation, but also take into account your local processes so that you can reach a rapid local decision. The plan is to go at fairly breakneck pace, I have to say, in following closure of the consultation deadline, which, as Wagner said, was the 14th of March, to receive the results of the consultation, think about what we need to do to amend the proposals. If we do, take things out, add things in, do whatever we need to publish the final guidance in April 2018, and probably fairly early April this year. So it is a rapid timescale, which again reinforces why I think it's really important that you do things now. You certainly don't wait until the end of the consultation period. So, but it's for you to determine what that looks like. And one of the things that we think you need to think about is actually where on the variation graph are you? If you've actually done all the work on this and you are down the bottom right-hand side on all of the graphs for the conditions, then you probably don't need to do much at all. But if you're further up, then you need to think about that. And of course, it needs to be actually consistent with your own policies for consultation and engagement, because it's your decision-making at the end of the day and your statutory responsibility. And as I said earlier, we have already now shared the broad level of spend with you so you can see what that looks like. So during this consultation phase, you can provide, and we would encourage you, please, to provide your own response to the national consultation for the conditions, whatever that is. We're expecting quite a lot of negative feedback from certain patient groups who are concerned about some of these things. If you are supportive as a CCG, and I would hope most people are because we're doing it on your behalf, we need to hear that, because if all we hear as part of the process is the negative comments, that outcome could be skewed. So please, if you are supportive, please say so. But you need to also think about what else you need to do, and that could be limited, it could be linked to your expectation on the guidance, as I've said, the outcome of anything you've already done. So for those CCGs who have already implemented this and have done really robust local engagement consultation, please make sure that we know that, because that will be helpful in shaping the feedback. And then any feedback from local engagement with a whole variety of groups listed there, but also critically, I would say, your own membership, so your practices. Because again, some anxieties are still coming out, and I understand them, about the GMS contract implications for some of this. I think some of it we can deal with, some of it is a bit more tricky. So again, it would be really good to get your member practices feedback about this. And we'll continue, obviously, to engage with the GPC because there are different views from LMCs across the country about this too. So, following the end of the consultation period, as I say, fairly breakneck speed, analysis and feedback on what we've heard nationally. Then, again at breakneck speed, the clinical working group will be reviewing all of that and developing finalised guidance, which would be published in April. And then, as we said, the expectation is that you then need to make your own local decisions, but you have to statutorily have due regard to the guidance, because it will be statutory commissioning guidance that NHS England will be publishing in April. You need to make your own decision on each of them, but you have to then, in doing that, have due regard to both local circumstances and the National Health Impact Assessment, but your own local health impact assessment, which may mirror or may be different to what the view is nationally. So that's all from us in terms of the detail. It's now time to hear from you in terms of questions, comments, reactions, feedback. All of those sorts of things would be hugely helpful. We haven't got anything that's come through yet at the moment. So if you can let us have questions, feedback. The audience for this webinar is CCG leaders, so we've got, I can recognise some chairs, some chief officers and CFOs on the webinar. So if you do want to make a comment, you do need to type it in the box, or we can unmute you. Ian, I know you want to. Yes, we'll unmute you. It's not that many of us, so you should now be able to speak freely, I hope.
You spot who I was through remotely, which is slightly worrying, really. So this is Ian Orpen from Bath and North East Somerset. We're interested in the commenting really on the general exceptions, the thing you were interested in around the vulnerable patients bit. And we used something, we had some wording slightly similar to that, but I think this is what you produce is better and more helpful around gluten-free prescribing, which we went through a consultation about a year ago. But as you said, with both with the Celiac Society and with our patient group and with GPs, there was anxiety and concern about that issue. But I think the wording you put together is really helpful. So as a GP, I would find that quite a helpful way of describing it. It gives us a nice frame. So I think that's a thumbs up from our perspective on that. So just thought it'd be helpful to give you that.
So that's good to know, Ian. It's amazing, actually. As a profession, you get very different takes from different GPs. So some like you feel that's sufficient, but I've also heard from a number of others who don't, who are really concerned about that. So crafting this such that it'll support the decisions and the discussions that you have is really important.
Yeah, and I apologise on behalf of my profession. We're, as you know, only too well, we're herding cats. Indeed.
Once we hear both, but all sides, I won't say both sides, because I'm sure there's more than two. So, so if you have questions, if you want to speak, if you raise your hand, and you'll see there's a box to raise your hand, then we can unmute you, and you can actually speak, and we can have a conversation as opposed to a slightly more stilted. Just type the questions in, but anything really. It'd be good to get your steer and view about the exceptions. So as Ian has raised, do you think it goes far enough and will be supported by your CCG and your local clinicians? And it would be good to get your take as well on what you think you need to do locally to be able to obviously take the final decision in April on each of the items. So if there are comments or anything you want to say in those areas, it would be good to do that. We will unmute all of you, then we can have a virtual conversation.
Hey, just while we're doing that, if I could just raise about if anyone has minor ailment schemes operating in their area. As a result of this guidance, you should consider what the impact will be on this minor ailment scheme. If you are one of the very few CCG areas in the country where NHS commissions the scheme on your behalf, we will be in touch with those CCGs directly about their minor ailment scheme.
Because there's an interesting dilemma of that, because I think if we are saying there's a point of principle to not be spending money on the medicines for these because they are lower priority, then irrespective of who's dispensing them, which scheme is prescribing them, you could argue that actually they shouldn't continue. However, if those minor ailment schemes are completely limited to vulnerable patients, and that you think that is the way in which you can manage this issue about social vulnerability, ability to pay, those sorts of things, then you might reach a different view. But I think you need to be thinking about the rationale for why you're either continuing or discontinuing a minor ailment scheme with community pharmacists in relation to that. Obviously, as Glasson said, we will be engaging with community pharmacies. I'm not quite sure how we're doing it, but we're doing it. And I'm sure they will have a particular take on this, as indeed do the rural pharmacies, which isn't supportive generally of this at all, actually. So now it's very unlike CCG leaders to be quiet. So come on, guys, you must have something to say, even if it's yes, keep going, Julie. You're doing this is what it's for us. It'd be good to get your take. Don't worry, Ian. Thank you. See you. Ian's got to go. It's fine. Anything from colleagues? Are you clear what needs to happen? Are you generally supportive and just want to get on with it? Or have we missed anything? You're all unmuted, so everybody's able to speak now. No? Right. Okay, well, we'll give it another couple of minutes, but if we don't hear any questions or comments from people, then we'll close the webinar early. Obviously, we must be meeting your needs, although you're not saying anything to us. So, Any comments, questions, what we've said? Can somebody just so that you are there? Can anybody speak to me? Okay. I'm hoping the audio hasn't lost us and you can hear me. But we haven't got any comments or questions from anybody else. So if that's the case, I think we won't waste your time because it's very valuable. So can I just reinforce the web consultation survey? There's the link. Please do engage with it and respond to it. As Barbara said, we're doing a lot of other consultation events, some face-to-face, lots of webinars, lots of groups. So hopefully you can both promote them to get your local patient populations involved in it, but also respond as you need to. So if you have any further queries that we haven't answered, or you suddenly realise there's things you want to say, you can email us at either of those addresses. So the first one will come obviously to NHSCC, the latter to NHS England, and we can get you can get responses to you. So you've asked for a copy of the slides. We will make available a copy of the slides, Philip, so that you can use them locally, and there will be a recording of this webinar on our website fairly soon after the end of it. So please do use that to talk to colleagues. So without further ado, can I say thank you to Barbara, thank you to Brian, thank you to Sue. We didn't need to hear from you, but lovely to have you on the line, Sue. And thank you to all of you for listening in. And I wish you a good afternoon, and I will see you soon, I hope. Thank you, and bye-bye.